الرحيم. الحمد لله. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد أشرف خلق الله أجمعين. سبحانك ربنا هديتنا لهذا وما كنا لنهتدي لولا أن هدانا الله. كل فخر وشرف وتقدير لأستاذي العالم الجليل دكتور مجدي خليل للدعم الأدبي والدعم العلمي اللا منتهي لجروب المابك، وتفضلوا النهارده بمحاضره شيقه جميله. انا اول المنتظرين وكل شغف ان انا عارفه ان انا هخرج النهارده بتجربه ثريه ومناقشه علميه رائعه. كما ارحب باستاذ الدكتور خالد ياسين، واستاذ الدكتور خالد ياسين ايقونه النشر الدولي وسفيرنا العلمي فوق العاده للعلم المصري في علم الهيباتوبيلياري اناثيزيا، والذي نتشوق جميعا لرؤيته لبعده ولا سفره، ان شاء الله يرجع لنا بألف سلامه. اهلا وسهلا بكم جميعا، اهلا وسهلا بالمابك جروب جميعا، وجميعا منتظرين ان يقدم لنا استاذنا الدكتور خالد ياسين استاذنا الدكتور مجدي خليل في المحاضره. وشكرا لكم جميعا، وشكر الله لكم جميعا هذا الجهد وهذا الوقت. شكرا لكم جميعا. تفضل يا دكتور خالد، تفضل.
السلام عليكم ورحمه الله وبركاته. First of all يعني لازم طبعا أشكر هذا الجهد الكبير لنقابة المنوفية بقيادة طبعا الأستاذة الدكتورة صفاء هلال. هذا جهد طبعا فريد من نوعه في منطقة الشرق الأوسط، أن يقدر نستطيع أن احنا نتواصل بسلسلة محاضرات كاملة مجانية وفعلا بتثري وفعلا فيها سبيكرز أقوياء. بشكرك جدا على الفكرة والاجتهاد والمصابرة اليومية على دعم المشروع حتى يصل إلى كل البوست جراديويتس اللي بيتعلموا في الأنستيزيا. النهاردة we have one of our famous anesthesiologists, Professor Magdy Khalil. For those who don't know Magdy Khalil, I've been working with Magdy Khalil since 1990. And both of us started in National Liver Institute as two first pioneers in liver anesthesia. Magdy went to France in his scholarship. Before he went to France, he did every effort to help me catch up with the UK scholarship. وانا طبعا ما نسلكش الكلام ده يا دكتور مجدي، يعني هو بيخلص ورقه وكان بيخلص لي ورقه. وفعلا احنا كنا على اتصال دائم ومشترك مع زميلي مجدي وهو في فرنسا وانا في انجلترا، وفي محاوله مننا ان احنا نشوف ايه التكنولوجي بتاع الليفر ترانسبلانت الخاص بالانستيزيا والانتنسيف كير، ونرجع بالخبره دي لمصر في وقت كانت بلدنا بتبعت اغلب مرضى زراعه الكبد لدول العالم الاخر، واحنا شفناهم كلهم في انجلترا وفي فرنسا واقفين ويتنج ليست، وفي الصين شفنا الناس دي كلها. فكان الهدف الأكبر إن احنا نرجع بالتقنيات المتقدمة للليفر ترانسبلانت لمصر. طبعا ما ننساش دور دكتور أحمد عباس رؤوف عميد معهد الكبد اللي كان دايما الله يرحمه يشجعني أنا ومجدي ويقول لنا طالعين فدائيين تنقلوا تكنولوجي وترجعوا. Professor Magdy Khalil is the anesthesiologist professor at the National Liver Institute, Manufia University. He is also the ex-dean of the National Liver Institute. كان له دور كبير جدا في إقامة مبنى معهد الكبد الجديد، 410 سرير يا دكتور مجدي تقريبا 8 أدوار ICU، 8 غرف عمليات، إجراء يعني كان صعب جدا. الناس كان وصلوا للأمل إن هو ما فيش أمل إنه يتبنى، لكن مجدي بذل مجهود كبير جدا، وفعلا الحمد لله الحلم تحول إلى حقيقة. النهارده مجدي هيتكلم على موضوع في غاية الأهمية. He will talk about how we can do major surgeries like liver transplant with no blood transfusion. In fact, maybe about in our last publication, 26% of our liver transplants in Manufia is blood transfusion free. The rest, they take minimal amounts of blood transfusion. So this is a very interesting topic that we will listen and hear and learn from Dr. Magdy, how we can do this work in liver transplant and in other also subspecialties. You need to understand coagulation very well. You need to understand blood transfusion and the needs of the patient. And you also must have in advanced technology in monitoring your coagulation. So please, Dr. Professor Magdy Khalil, go ahead with your lecture.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. أنا يعني very happy to be part of the MAC أو MAPIC زي الدكتورة صفاء ما غيرت الاسم، لما كنت بحب ماك عشان يبقى ماك أنستيزيا. وأنا أحب دلوقتي يا ريت كلنا كمان نضيف للسبيشاليتي بتاعتنا أنستيزيا ICU and perioperative physician. I'd like to be known as perioperative physician. هنقول حاجه انا ما احبش ابقى بايظد، بس انا بايظد. انا I hate blood. ببدا خلاص انا I hate blood. I hate blood. يا ريت اللي عاوز يعلق يبقى انتراكتيف و just بس raise his hand عشان ما يبقاش فيه خلط. انا I hate blood transfusion. I declare from the start I hate. ولو كنت اقدر اشرع اني احرمه لحرمته. انما استغفر الله العظيم انا لا بحرر ولا بحلل ولا بحرم. كمان في نفس الوقت I hate blood loss. يعني الموضوع مش موضوع blood donation بس، لا blood loss. النهارده في الميتنج بتاعتنا مش عاوز اقول presentation. It is a meeting. Our meeting will speak about 4 items. Blood transfusion is more than an enemy. Blood transfusion is more than an enemy. Number 2, threshold concept of transfusion. Threshold concept of transfusion. ثم patient blood management. ثم how to minimize bleeding. الأربع النقط دولت، كل نقطة ممكن هنبقى بعدها في حد رافع حاجة. Can you do it by English? We have some. Okay. مفيش مشكلة خالص. If you want in English and you want in French, si vous voulez en français, on peut parler aussi ensemble, aucun problème. So I'll continue in English. There's some participants are from the Arabic area. So we'll divide our meeting topics today to 4 items. Blood transfusion is more than an enemy. This is a definition. I said I like it. It's not written, it is my own language. Blood transfusion is more than an enemy. Threshold concept in transfusion and patient blood management. Patient blood management was known a long time. I remember that Miller, the big textbook of anesthesia, since a long time has changed the 3 chapters of blood transfusion into patient blood management and how to minimize blood. Let's go to the first, some comments. Thank you. Okay. Let's go to the first item. Blood transfusion is more than an enemy. Blood, please consider that you are doing something illegal, something not prohibited by law, something prohibited religiously. Why? We all know these abbreviations. Transfusion reactions, transmission of infection disease, TRALI, which is transfusion-related acute lung injury, TRIM, which is transfusion-related immune modulation, TACO, which is transfusion acute circulatory overload, and TAS, which transfusion-associated sepsis. This was known since a long time in the British Society of Anesthesia under the name of SHOT. Serious hazards of transfusion. But as Khalid just reminded me that I went to France about 30 years ago, I did 1 liver transplantation for 1 patient, Italian patient. She only took 1 pack of blood for CS. This was in Italy, not Egypt. Italy. And she caught virus C, which developed cirrhosis and HSC like the any course, and she went. This was amazing for me and was hurting to me. But at that time, the only fluid taken to liver transplant was RBCs and plasma. So if the blood is a man, I could kill him. Look to infection complications. One of the methods that said always by surgeon that I give blood to increase immunity. I give blood to improve healing. This is not true. And on the other side, risk infection complication associated with blood transfusion in elective spinal surgery. Look to the blood transfusion was associated, was increased risk of surgical site infection and urinary tract infection. So it is not only blood or RBC's donation or RBC's transfusion is not doing the healing and not doing the immunity, but on the contrary, it is associated with increased risk of surgical site infection. What about blood transfusion and cancer? Perioperative transfusion and prognosis of colorectal cancer surgery, a systematic review of MEDAS, which they found, this is 2019. They found that the rate of recurrence is increased in colorectal surgery. Another study about the prostate, the impact of blood transfusion on survival and recurrence after radical prostatectomy, a prostate cancer, a systemic review, which they found that conclusion defined from the current meta-analysis demonstrates that prostatic blood transfusion was associated with adverse survival and recurrence of cancer patients undergoing radical prostatectomy. Liver perfusion closed. Okay. Third, blood transfusion in liver resection. Conclusion, blood loss during hepatectomy is common and several risk factors can be identified perioperatively. Blood loss and blood loss during hepatectomy, blood transfusion during hepatectomy was associated with post-operative morbidity and mortality. A lot of evidence. The perioperative transfusion caused dramatic negative effect on long-term prognosis and increased short-term complication after colorectal surgery. Also, blood, a lot of people is coming and disturbing my screen. Can anyone please be responsible about the admission of the new?
Yes, Dr. Magdy, I'm responsible for this. Just carry on with your lovely presentation. Okay, thank you.
Also, the balance between pro-inflammatory and anti-inflammatory sepsis in the ANSU, they concluded that blood product transfusion may exacerbate the initial immunosuppressive response to sepsis. So all of this indicate that blood transfusion is hazardous. And even if it is not hazardous, as we will explain in the second session about the threshold concept, that if we are giving the blood, we consider that blood is as effective as our normal blood. Our normal blood is carrying the oxygen to the cells, okay? And the lifespan is 120 days. But the reserved blood is not as efficient as normal blood. Something called red cell storage syndrome, where if we look to this, we will find that the pH is decreased, 2,3 DPG are decreased. The 2,3 DPGs are responsible about the donation of the oxygen to the cell. If it is increased, it will facilitate the transport of oxygen from the RBC to the cell. If it is decreased, it will hinder. And this is a defense mechanism, natural defense mechanism with anemia. If the patient will have anemia, he will have many mechanisms to increase the donation of oxygen to the cell. One of them is 2,3-diphosphoglycerate. So if it is diphosphoglycerate is increased by 14 days, so minimal. Oxygen saturation will be more, lactate will be more, potassium will be more, free hemoglobin will be more. So if you consider that you are giving blood without any harm, you are dreaming. The second part of the blood component is plasma. Plasma, we consider it is, as we'll see in the second section, that we give more and more. But if even if it is mandatory, it might have trally. Look to the percentage of trally in ICU patient. About 5 to 8 patients transfuse with plasma. Even if it is necessary, they will catch trally, and mortality will raise from 30 to 50%. So if you are giving plasma to 100 patients in the ICU, this might have 3 to 5% death due to direct action of plasma. The last session, the last part of the blood is platelets. Where platelets have expression of ABO antigens, ABO unmatched platelet yield lower platelet increment, slower short survival, reduced hemostasis property, increase exposure to expression to P-selectin. So even platelets will not as effective as natural platelet, but carries a lot of harm to the patient. So after this first part, who agrees or disagrees that blood products, blood are harmful, or am I exaggerating? Now it is open for discussion. خالد، لو انا ريدي ان انا اي حد عاوز يعارض او يوافق، ولا كله قفل المايكات ومشي؟
لا، ده هو المايكات is closed.
انا فاهم. انا خلاص دلوقتي ممكن الدكتور
Can we leave the discussion? Would you like to leave the discussion till the end?
لا يعني ده الجزء المهم جدا. If you are not convinced by this idea, you will not follow me.
Okay.
First of all, my first part is to convince others that blood is harmful. Blood is like you are doing something illegal.
Dr. Magdy, Prof Magdy.
Do
you hear me?
Yes, sure.
Yes.
Yeah. Thank you, Prof Magdy, for informative presentation. Really, I was an argument. I'm
Professor Dr. Yasser Tobli, Yasser Muhammad Rida. This is our great Professor Yasser Muhammad Rida.
I was happy by this presentation because I went to an argument with one of my juniors about blood transfusion. He want to give the blood. I don't like to give the blood. The hemoglobin was 8.9. But the patient bleed a lot because his hemoglobin was 16. And because I'm senior, I just was waiting for your presentation. And I asked him to attend this presentation because this is what I believe like you. And thank you for this informative introduction, because now he's looking for the presentation, and he tell me that I'm convinced now. And thank you for that.
Okay, thank you. You know, in education or learning in general, it is a planned experience aiming to permanent change in knowledge, skills, and attitude. So the most difficult part of transformation is the change of attitude. This is very difficult. That's because it is difficult to be taught and difficult to be assessed.
My question to you, Professor Magdy, is when do you think? When do you think?
Question inside the curriculum or outside the curriculum?
Yes, yeah. When do you think it is time to give blood transfusion?
Yes,
because some patients, example one, patients with myocardial ischemia with problems cannot tolerate maybe. So when do you think we should give blood transfusion?
This is the second part, recent concept. Second part. First part, that I want to convince you that blood is an enemy, not only harmful, it is an enemy.
Definitely, it is not good to give blood transfusion. It's like giving an organ transplant, but sometimes we are forced to use it in certain particular situations. Well, the lesson that we want to say, or the message, is we should reduce blood transfusion.
Yes.
as much as we can.
Fourth part. This is a fourth part.
Yeah.
I consider blood. As I've said, if I can do halal and haram, but I'm not authorized to do halal and haram. But if the verse states that in some prohibited parts of our activity, فَمَنْ اضْطُرَّ غَيْرَ بَاغٍ وَلَا عَادٍ, if you are considered, if they enforce it to do blood transfusion, just do it. But above that, you are not free to do that.
2 months ago, I had an argument with a German professor. He was visiting Riyadh, and we were talking about blood transfusion, fresh frozen blood transfusion, and others. And he told me that maybe during the last 10 years in liver transplant in Germany, they didn't give any fresh frozen plasma. And definitely they didn't give any cryoprecipitate in liver transplant. So this shows you how blood transfusion is being reduced dramatically in Europe.
Khalid, please, I divide my meeting items to 4 parts. This is second and third part. So don't jump, please.
Okay.
Anyone
Prof. Magdy, sorry, this is for just as a comment, and I want to agree with me. I understand from your presentation, and I believe this blood transfusion is organ transplantation.
Sure.
All the problem with organ transplantation. And do you agree with me with that?
Yeah. Blood transfusion is should consider as drug transfusion, drug administration, volume administration, and organ transplantation. 3. I totally agree. And if you look to the last slide, which is shared now about the cell fragments from the platelets and RBCs, these fragments will go to the recipient and will change a lot about the cytokines and so on. I'm sorry that in this meeting, which is online, I don't want to go through many academic philosophies, theories, sometimes like that. I just let this, so if you are going to home and read. But if you look to this slide about the supernatant of the platelet and the part of leukocytes, it is actually, as I said, it is an organ transplantation to the recipient. Okay. Coming back to the
Dr. Magdy, just I have a very small comment. A point of conflict or a point to be clarified from you now, please. We speak about blood transfusion in elective surgeries, or we can add in trauma or postpartum hemorrhage or any accident that have massive and severe abrupt blood loss. It is the case in this situation also, or in elective major surgeries. Please clarify this point.
Dr. Safa, I divided my presentation to 4 parts. Only the first part, I'll speak about these answer these questions in the fourth and third part.
Okay.
Please let me know. We are created from God. Our body is created from God by a great advantage is that the reserve, the physiological reserve. I always talk with my colleague in my department at who is the anesthetist. Anesthetist is a physiology keeper for those who lost the physiology, the reserve. Again, who is or what is the function of the anesthesiologist? The anesthesiologist is a reserve keeper for those who lost the reserve or declined the reserve. So God created us with a lot of reserve. So if we have hemoglobin, for example, 15, 14, 13, like that, they are more for us than which is needed. We need about 6, the threshold. We need 30% of plasma. We need 50,000 of platelets. So this is our need. Beyond that, this is a reserve. This is number 1. Number 2, we are not dealing with plastic mannequins. We are dealing with a physiology renewal each second, each minute, each hour, each day. All of this is acting. So if you have a patient, for example, with hemoglobin 7, don't rush this, because tomorrow he will be 8 or 9 by himself without any treatment. So look to the threshold-based transfusion concept, which is now adopted for all transfusion medicine. So let's revise why we give blood. We give three components: RBCs, plasma, and platelets. Why we give blood? It goes without saying that we give RBCs for oxygen carrying capacity, no more. If you have a problem in your mind about the oxygen carrying capacity, give RBCs. If you have a problem of coagulopathy, give fresh frozen plasma or concentrate or platelet or cryoprecipitate. Please, for each time you give blood, ask yourself, why am I giving? Sometimes they say that to increase the volume. No. To increase, no. Coming back, which is the physiological reserve. Look to this. Ultimate function of the cardiorespiratory system is to provide oxygen optimum to cellular respiration. We have 4 types of hypoxia. We will speak about this one, which is hypoxic hypoxia, anemic hypoxia, stagnant hypoxia, and cytotoxic hypoxia. We are now speaking about anemic hypoxia. Anemic hypoxia. Anemic hypoxia. Anemic hypoxia. This means that the oxygen carrying capacity of the body, the oxygen carrying capacity, which is dependent on 1, hemoglobin, 2, saturation, 3, cardiac output. So hemoglobin is one of the factors donating oxygen to the cells. So your decision might be changed from, for example, one patient who has hemoglobin 7 at the age of 20, or a patient with hemoglobin 7 at the age of 80. That's because the cardiac output is different. So think about the all 3 parts of the oxygen concentration. Coming back to which is the threshold of giving RBCs. Below 6, give blood blind. Above 10, don't give blood blind. There is no question to give blood above 10. There is no question not to give blood below 6. What is about 8? 8, you have to find a strong indication to give blood. So 8, 7, or 8 is not synonymous to blood. For example, now even price-wise, not physiological-wise or complication-wise, price-wise, if you in doubt that the 8 is not sufficient to the patient, you can do two simple lab tests: lactate and venous oxygen saturation. Venous oxygen saturation will denote about the extraction. If it is high extraction, so 8 in need. In normal extraction, so no need. The price of this is much than 10% of the price of blood transfusion, even if it is useful. Coming back, this review, Khalid BGA 2018. What about which is really dangerous? Anemia or transfusion? He quote a very interesting study done about the Jehovah's Witness. Jehovah's Witness, who it is due to religious reasons, they prohibit completely blood transfusion, even if you are going to die. And they catch it, which is more dangerous in thinking. We always fear anemia, the patient will go. But actually speaking, transfusion is more hazardous. Look to this Jehovah's Witness, 300 patients who did surgery and went to not to give blood even at a hemoglobin of 1. Of course, 1 to 200% mortality, 2 to 3, 54, 3 to 4, 25%, 4 to 5, 3, 4%, and from 5, 6, 9%. But there was no death in 30 days period in patient with hemoglobin level of 7 to 8, sorry. and the reference is published in Transfusion Medicine 2002. Someone that said it might be some morbidity, like for example, the wounded dehiscence, infection, and so on. Also, they found that no morbidity above 6, the same criteria. What about the morbidity? Cardiac events, bacteremia, pneumonia, deep vein infection, and so on. This is a strong clinical proof that 6 is enough for adult patient with no comorbid. Just answer the question of my dear colleague Khalid. If the patient is compromised only without significant evidence is not a right cause to give. Just prove to yourself. For example, if your patient has tachycardia, the patient is falling from standing, the patient is hyperventilated, the patient has higher lactate, the patient has oxygen extract and white, evidenced by venous oxygen saturation. All of these are evident that the patient is in need to more oxygen to the cell, and 7 to 8 is not sufficient, so give him. But 7 to 8 by itself as a number is not an indication. Even as Professor Yasser just asked now, if the patient has fallen from 13 or 14 to 8, no problem. That's because God created us to defend against anemia, but not against blood and massive transfusion. This is very important. What happened? Anemia. What happened to anemia is oxygen sensing. Just anemia as suddenly or chronically appeared, there will be liberation of erythropoietin from the kidney, will go to the bone marrow, will go to the RBCs. Now, I'll ask a funny question about how many RBCs are produced per day. It is an Google knowledge, not a secret, but just guess. Just guess how many RBCs are yielded per day. As a joke, bone marrow, 200 billion new RBCs per day. Actually speaking, if it will be easily calculated, we have 5 million RBCs in the body. The half-life is 120 days. So it appears that we have to produce more than 1 by 120. So that's coming back to what I said. We are not dealing with plastic mannequin. We are dealing with a human body that is functioning. It's functioning. So even if the patient is anemic now, tomorrow will not be anemic. Just what can I do to him? But for my junior colleague, that oxygen carrying is one part of the theory. But oxygen utilization is another part. For example, me and Dr. Khalid, for example, went to one theater and we made an argument not to give blood and give blood. So if they want to judge between us, they will do lactate, tachycardia, and venous saturation. But what about the oxygen utilization? Don't say that 8 is enough in a patient, for example, who is 70 and he was doing, for example, weapon operation, and by mistake, I'll say it's a mistake, he lost temperature and he is in pain, and he went extubated immediately in the OR and went to the recovery room with shivering and pain and shall 8 will be enough? No. So keep in mind that you have to balance between oxygen delivery and oxygen. Even 10 might not be enough if he has these two many factors. Some of them is inevitable, but much of them are inevitable and could be prevented, like hypothermia, like shivering, like pain, like convulsions. Okay, so keep in mind. Coming to in Arabic, الإيد اللي بتوجعني, that sometimes they sometimes no, but a hepatic patient with liver cirrhosis, we have to keep the blood going. This is nothing. In this elegant gastroenterology journal, management of varices and variceal bleeding, I will not speak about many items about various, but I'll speak in 2 comments about the transfusion. About the RBCs, they said that transfusion of RBCs using the restrictive strategy, meaning initiating transfusion when hemoglobin is less than 7 and maintaining a goal for 7 to 9, this approach has lower rebleeding and mortality rate, especially in those with our. Okay, so even in cirrhotic patient with variceal bleeding, active variceal bleeding, they recommend not to give blood, as if giving blood will increase the rebleeding. RBCs maintaining 7, which is restrictive strategy, and maintaining goal for around 8. This approach has lower rebleeding and mortality rate. What about transfusion? Transfusion of fresh frozen plasma is not recommended, as it will not correct coagulopathy and may lead to volume overload and worsening of portal hypertension. So even in cirrhotic patient with variceal bleeding, giving a blood is hazardous. Fresh frozen plasma. Okay, we finished RBCs, going to the fresh frozen plasma. Fresh frozen plasma in my locality is doing a lot of crimes, like, for example, giving fresh plasma 3 days before the operation in hepatic patient for the hernia, for example, giving 8 hours before the operation. This is false, but what I speak about the hazard. 30% of each coagulation factor are sufficient. So if you are giving plasma to a patient who is in coagulopathy and evidenced by laboratory or rotum, not blind, not because he is hepatic, not because he is coagulopathy. If you have a proof that he will bleed either by laboratory or rotum or TEG, give blood. What is the dose? The dose from the physiological basis, physiological reserve, 30% of each coagulant factor are sufficient to complete normal hemostasis. Normal hemostasis is done only by 30%. So the dose is 30%. We have 3 liters of plasma in our body. Khalid, رحت فين Khalid? Khalid, you are bored? كويس. Dose from 10 to 15 ml per kg, used immediately when needed, immediately, not on chronic basis. Fresh frozen plasma for 3 days is useless. These are the coagulation factor necessary for normal hemostasis. Fresh frozen plasma, whole blood is not a right decision. 30% of plasma volume is repeated if situation is bleeding is coming again, but not on a chronic basis. Never given as chronic repeated basis. Never given as a volume replacement. Never given as nutritional therapy. Never given as albumin replacement therapy. Carries a highest mortality, highest risk of trally. Fresh frozen plasma in patients with cirrhosis and coagulopathy effect on conventional coagulation. This is this article is present from Dr. Muhammad Abdulatif for me, as you said. So they found that giving plasma to hepatic patient on chronic basis is useless and hazardous and has no effect. So before transfusion and after transfusion, no change in the coagulation, no change in the density of coagulation. Last part, platelets. Platelets, if your patient is less than 10,000, give. If your patient is less than 20 and you not to do invasive procedure like central line, give. If your patient is above 50, do major, ultra major operation. No need to transfuse. For example, your patient has a platelet count above 50. Just an advice came to me from one of the clinical pathologists. If you have platelet count less than 100, sometimes it is done by Coulter apparatus, so might not be accurate. Please revise this count either manual or by laser beam apparatus. So this is a threshold concept, and the American Association of Liver Disease doesn't recommend the routine prophylactic use of fresh frozen plasma or platelet before paracentesis. Lastly, the decision to transfuse platelets must always be weighed against the platelet antibody production, transfusion reactions, and the possibility of increasing portal venous product. This is AASLD. It is like the holy book for all hepatologists. Coming to take 5 and open the question for. I think that I answered some questions that was raised between the first part and second part. If anyone has any comment about this threshold concept, I'm ready.
You did answer very important questions, which I still notice in among the physicians, especially the hepatologists. They keep writing for their patients 1 fresh frozen plasma every 8 hours, and they give it as an albumin support, and they give it as fluids. This is totally wrong and is malpractice. They should not really use this. Fresh frozen plasma is minimally now being used anywhere because of the replacement of other blood products and ampoules, which are available now. So shall we talk about this, Dr. Magdy, or leave it till the end of your lecture? Alternatives of blood transfusion.
Please repeat again the question, please.
I mean, fresh frozen plasma is now minimally used in many European centers, and they have been replaced by.
Please, Khalil. We are living in Egypt and Arabic area. It is highly used.
I know it is highly used, but it is our duty now, like in other countries, neighbor countries also, to reduce the use of fresh frozen plasma by using other alternatives for fresh frozen plasma, like what patient prothrombin complex concentrates, like fibrinogen ampoules. These ampoules are now available in the Middle East. They are now available in Saudi Arabia. I don't know if in Emirates it's available. And in Egypt, just before this webinar, I spoke to the representatives to try to make them available in Egypt as well, because this would definitely reduce the fresh frozen plasma. You must have an alternative. You mentioned that fresh frozen plasma can cause damage to the patients, can lead to immune status alternation. Then we have to go through what most of Europe is doing now. They are using these ampoules to replace the fresh frozen plasma.
I minimize, we have a lot of knowledge about blood transfusion and anesthesia coagulation. I minimized my presentation, my talk today, just to which is available and what to be corrected.
Okay. دكتور مجدي بليز انا عندي كومنت في النقطه بتاعت اللي هي the lowest threshold اللي احنا نبدا نعمل عنده transfusion. Maybe it is influenced by the patient age, patient sex, comorbidity, and the type of operation the patient will going to have. If these are influential factor, may influence the lowest threshold that we can do transfusion for him. Patient age, patient sex, comorbidity, and the type of operation.
Excellent comment, Dr. Said. I just remind all of us about the threshold concept that below 6, give without thinking. Above 10, don't think about to give. What about 7, 8, 9? All the factors that you raised are very important, and you have to solve this problem by calculation. If you have a patient who's 8 and he has lactate increased, has tachycardia beyond the level of agent 6, has falling when standing, and he has oxygen extraction from the venous oxygen sample increasing, so give him. But if you don't have all of these, don't give.
Okay. I mean, if we have a measure,
it is not a silent fear. It is a calculated fear.
Yes, it is not a stony hard information. No, it is malleable as regard the patient age, the patient comorbidity, the type of operation the patient will be operated upon. So we haven't a stony hard rules in this area. Okay.
We have a calculated evidence.
Okay. Okay. Yeah. Thank you. Thank you.
So,
Prof Magdy, sorry.
Yeah, sure.
I have a small question. I needed to hear it, the answer from you and for even my colleague.
Big professors always ask big questions, not small questions.
Yeah, so I have a question about the drawbacks of blood transfusion related to the volume or not, and how to minimize these drawbacks. If we need the blood, how can we minimize the drawbacks of blood transfusion? Thank you.
Volume expansion by blood is known as TACO, as the first slide I did. TACO, transfusion acute circulatory overload. To prevent this is not to give blood when it is not needed. That's because I said that our gut created us with a defensive mechanism against anemia, but not against overload. If you have overload, like for example in cirrhotic patients, we will increase bleeding, so we'll have a lot of problems. So the only solution for TACO is not to give blood or give the amount just necessary. Just threshold concept. Remember this statement, threshold concept. I'm just giving the physiological part if the physiological part is below the level which God created us. God created us with hemoglobin 15, 14, 13, but we can tolerate up to 6. If you below 6, give. God created us with coagulation doing well with 30%. If it is less than 30%, give. Acute.
Or Magdy, we can preserve the patient's own blood by using red cell saver technology, for example, during elective surgeries.
As if
like we use in National Liver Institute. You can use it in liver transplant. This you protect the patient and give him his own blood.
As if Khalid, you are going to end the meeting. You are always asking, speaking about the next part.
Next, okay.
دكتور مجدي السلام عليكم.
عليكم السلام.
وسام سلطان مع حضرتك.
أهلا وسهلا.
Thank you, Dr. Magdy. I have just a question. If we have two patients, one of them, the basic hemoglobin is 14, and the other one is 10, and both undergoing a surgery, and the post-operative hemoglobin
the last word I heard is 14 and 10. Then was
repeat your question, Dr. Wissam. The voice was not clear.
Oh, sorry, because I'm on the way. Okay, 14 and 10, both of them undergoing a surgery, and the post-operative hemoglobin for both one R7. The hemoglobin post-operative for both is 7. Are they treated in the same way?
Actually speaking, the number 7 is both are treated in the same way. Both are treated in the same way after calculation of the is it physiologically reserve sufficient or not. If you have normal lactate, if you have normal oxygen extraction in the venous sample, so no need to give, even for those who went from 14 to 7. I know this is always like in Sin and Arabic, the excuse of the surgeon that this is acute bleeding, chronic bleeding. No, it is always the same. We are dealing with a human body which is physiologically active. This 7 from 10 or 7 from 15, tomorrow he will yield RBCs. Tomorrow he will yield coagulation factor. Tomorrow he will yield platelets.
So our great Prof, Dr. Magdy, please. Dr. Magdy, I will comment about the question of Wissam. He would like to ask you if the patient is abruptly downhill and he was 14, his hemoglobin 14, we should treat him as he is. Yesterday was 7, the last week was 7. It is okay for you just to measure lactate or central oxygen. This is more enough. And will be treated as both the same base. Okay.
It is like the salary. It is the salary. If you, for example, if you have two junior staff in your department, one of them is taking 10,000 salary, and the other is taking 5,000. But the expenses. But for this 7, for just announcement, great announce. If you have this patient who went from 14 to 7, and you extubated him on the OR while he is hypothermic, while he is shivering, while he is in pain, he will die. And don't say that Magdy said don't give.
Yes.
You have to balance between it is all hemoglobin is only one surrogate of one part of the oxygen carrying capacity. But what about the giving? So don't say that I'm keeping the patient 7 as was said in the presentation. No, give. This patient is best to minimize the oxygen utilization. Just at time he will pass this obstacle, the wishdom, and will go by himself to the normal coagulation, normal platelet, and normal RBCs.
So allow me, Professor Magdy, that we have 4 functions for the hemoglobin. Number 1 is the oxygen carrying capacity. Number 2, a buffer mechanism. Number 3 is vasoplegic effect, and number 4 is yes.
I know, but 6 is enough. And you see from the slide of your witness, which is done after 2002, which is a little bit recent, not from the old, that they went normal above 6. No mortality, no morbidity.
Okay, yes.
So, Dr. Magdy,
so we can summarize. It is the patient condition and the circumstances we say, okay? Yes.
Yeah, I have just another question. So supposedly we are assuming that patients will, with the physiological reserve response of the body will compensate this after day and 2 days or whatever. So do we believe that this patient will have under these circumstances?
Wissam, your question is freezed. Your question is freezed. Please ask it again, as it, your net was freezed.
Yes. Hello.
Okay.
Yes.
Okay.
Mobile interference.
Do you hear me now? Do you hear me?
No, not. You're not. Your voice is not clear, Dr. Wissam.
Hello. Is it clear now, Dr. Khalil?
Yes. Now it's clear.
Okay. Supposedly, we are assuming that the physiological response of the body will compensate for the hemoglobin drop or whatever after 1 day or 2 days or more. Do we believe that the physiological conditions of the patient will be normal or properly enough to compensate under these circumstances?
Yeah, I believe and I agree.
Patients.
As Khalid said, we read a lot about not to give blood, and in our practice in the institute, by clinical evidence, by lab evidence, by instrumental apparatus evidence, that we are going right not to give blood.
Okay.
Okay.
Okay, Dr. Magdy.
If you can visit us in does threshold increase in order to increase oxygen capacity in cirrhotic septic patient? Perhaps came a little bit late, that because in one study I showed that giving blood too much to the septic patient will increase the pro-inflammatory and will harm the sepsis. That is, the answer has been answered in the first part of the presentation. Now, as we said, we are dependent upon the physiological. What about the perioperative physician? I said I'd like to be known as perioperative physician. If you have a patient, the patient who has hemoglobin 14, it's not problem. Even if he lost 3 liters, no problem. But if you have a patient who has hemoglobin 8, 9, by force, you will give him blood because he will lose. It is not tonsillectomy, and even tonsillectomy might be need to blood. Patient blood management. Patient blood management. This I sometimes question. You need to adopt a lower threshold for those who has chronic anemia. Okay, incisional disease. I'll tell you as to, yeah. If you can calculate, yes. Me, I'm against the blood all over. I'll tell a story now, but this story was strange. Okay, coming back to patient blood management. Patient blood management. This term, as I said, has been changed in Miller textbook from blood transfusion to patient blood management. Patient blood management means how to utilize the patient himself to solve the problem of blood transfusion. Again, how to make the patient himself by your knowledge and the drugs and techniques and to be a reservoir for himself. This is in summary. Simply, that's because might be one day patient blood management. Think about preoperative, intraoperative, and postoperative. Putting in your mind that zero blood. I'll give no blood. I'll be not in need to blood. Preoperative. I like one statement was written in American book that don't play catch up with the patient. Don't play catch up with the patient. Patient is faster than you. If the patient will step forward one step before you, do not catch him. If you have a patient with anemia, why to let him to go and blood loss and you will be in need by force to give blood? I have a time and I have a physiology and I have drugs and I have many, and I have nutrition to prevent him to going down. Simply. If you have a patient with, by definition, female below 12, male below 13, this is by definition is anemia. Test for ferritin. If the ferritin is low, this is iron deficiency anemia. Correct by iron therapy. Correct by B12. Correct by folic acid. Correct by nutrition. Raising is like a banger. If he has a higher ferritin, so it is not iron deficiency, give erythropoietin. So it is simple like that. If you are going to want to back to many literatures about the patient blood management, we can go. But the philosophy is to prevent the preoperative anemia. Okay, iron therapy, either I think Professor Safa, that the most clever surgeons or OB-GYN are always treating anemic pregnant women with iron therapy. So this experience is very good. Okay.
All the females, so sorry for your interruption, sir. All the females under cesarean section have a patchy discoloration at the gluteal region. And I asked for them why that it is the IM iron therapy, and I know she is anemic, of course. Yes.
For thrombocytopenia, even if it is lower than 50, and you can raise these are drugs that increase platelets count, and this is approved by FDA. I don't think this is not known, but now we have it in Egypt. This is proven, but the only disadvantage, it might take about 5 to 12 days to produce the elevated level, the elevated desired. But we have drugs to increase platelets count if it is less than 50 with no need to transfuse. The last part is how to minimize bleeding. Sometimes we increase bleeding by our responsibilities. Normally, acute disruption of the vascular tree by surgeon in bleeding. But can we be insulted as a cause of bleeding of it? Yes. First of all, think about the home medications. Non-steroidal, aspirin, platelet inhibitors, long-term anticoagulant, herbal. This is one of the major problem now, herbal supplement. Herbal supplements are exceeded, and not many of us know that this has an effect on the coagulation. So please be cautious about the history before operative. Should be stopped at least 14 days before surgery. Hypotensive anesthesia, we have a very good experience about it. I know now might be prohibited in Western hypotension, but hypotensive anesthesia with dexmedetomidine has advantage of lowering oxygen consumption as we see, minimize blood loss and maintain superior hemodynamics in comparison to nitroglycerines and esmolol. This study was published by my colleague Khalid. Intraoperative effect dexmedetomidine infusion during living transition. Just so here that the group was not dexmedetomidine has higher oxygen consumption. So even with hypotension and bradycardia during dexmedetomidine, the oxygen utilization is that which is a very significant effect of dexmedetomidine, better than all other factors decreasing the blood pressure. Also, be cautious. You try to use this apparatus to prove that you have a coagulopathy or not coagulopathy. That's because coagulation factor, we have said that it is normal if you have coagulation factors above 30 to 50%. So you might have, what is the explanation that you have a normal PT or normal PTT or normal INR? Nothing. You interpret by yourself that he has a very good bleeding or a tendency to bleeding or not. No, it is your mistake. INR, PT or PTT means the answer of how many coagulating factors are present in the patient blood. For example, I'll ask you a question. If you have a patient with purpura, will bleed or not? Will bleed. But if you ask him to do PT or PTT, it will be normal. But Rotem will explain a lot about this patient. Antifibrinolytic drugs like tranexamic acid, now it is adopted in cesarean section and many neurosurgery. Effective intravenous tranexamic acid in perioperative bleeding. It is shown that minimize bleeding and minimize blood loss and minimize blood donation. Some very trivial interest that core temperature control will decrease, but with each degree increase blood loss 16% and increase transfusion requirements by 22%. Also, it is very easy to have this Berhagar or any enforcing hour. Lastly, what can we do for our community? What can we do? Look, at the end of my meeting presentation is to do this. Might be something serious, might be something joking, but they did research about the evaluation of blood cell transfusion practice and knowledge among cancer surgeons. Thank God we don't have a surgeon in our meeting today, but they found that, strangely, this surgeons varied widely in their transfusion practice. This is number one. And knowledge, further education, further regarding transfusion medicine practice as well as transfusion alternative can lead to a patient improved outcome, patient blood management, and program may help inform individual surgeon practice. So they found in their locality, in the cancer surgeon in US, it was in December 2020, that surgeons, the problem with surgeons is that they are the part of the medical service facing the patient. Patients always believe in the words of surgeon better than anesthesiologist or perioperative physician. So they have to find a solution for this problem, that because surgeons overuse blood and blood product in their blood. So they admitted that they have the problem, and they want to do an educational program for surgeons about transfusion medicine brackets, as well as transfusion alternative improved patient outcome. I'll answer my question. To me, can we live without blood transfusion? The answer is yes, except in two conditions: massive polytrauma and obstetric emergency. So we can live without blood transfusion. Blood is like any drug, has main side effect. I consider blood only in massive polytrauma or obstetric emergency. Thank you, thank you, thank you.
Yes, Dr. Magdy, thank you very much. An excellent lecture, as usual. You touched a lot of points, and you arranged your lecture into 4 parts, which is very interesting. And there was an interaction with the audiences. I think it's a very good lecture, and we learned a lot from it. The floor is open for questions. I can read here a comment. Professor Magdy, thanks for the lecture. Autologous blood transfusion using cell saver can be an alternative. What do you think, Dr. Magdy?
Autologous blood transfusion has many applications. Number one, patient donation. If you have a patient with hemoglobin, for example, 14, 13, something like that, you can donate him for himself. The only advantage of this, it will be as much as we can early, not stored. Number two, it will need to any viruses, so it will be costly low. It will be free of any side effect like virus and something like this, because for himself. This pre-operative. Intraoperative, we has another solution, acute normovolumic hemodilution. Number three is cell saver. So, but I minimized my talk just to because if I open this, for as I said to Khalid, we have a lot of experience about that. If we might speak up to tomorrow.
Yes, I think that cell saver is being used very widely in the National Liver Institute and in many other liver transplant centers. And nowadays, our colleagues
and also Khalid pre-operative patient donation for himself. We did in
yes.
Patient, I think 2-3 patients earlier in Liver Institute. Patient had
that's right. We also had a research thesis.
That is the patient restores his amount of blood and RBCs and platelets and so on. So it will give to him twice, one by donation and another one by stimulation, more production.
Yes, so the availability of a cell saver always in the OR or close to it is very important. You talked about hemodilution during surgery. This reminds me of the thesis of Dr. Iman Sayed in our department. She also did the good work about hemodilution, donating the blood before the surgery and diluting it with equivalent amount of normal saline. So that's a very important topic. Any further questions in the chat? Okay. Anyone?
Dr. Khalid.
Yes,
I have a comment. Thank you, Dr. Magdy. It's a very
can you present
interesting
yourself?
topic.
Who is talking?
Wissam. This is Wissam Sultan, our associate professor. Wissam Sultan. Welcome, Wissam.
Thank you, Dr. Khalid. Thank you, Dr. Safa. Thank you, Dr. Magdy, for your interesting topic. For my practice, I'm very conservative in blood transfusion. That's to not misunderstand me. But actually, I believe that the blood is like a weapon. We might kill a patient with that, and we might save a patient with it. And we are still working in Egypt. We are stuck to the the medical legal aspects. And
Yes.
if we have patients have dropped the hemoglobin post-operatively, how many grams, it doesn't matter. But if the patient developed mortality for any reasons, I will be the first one to be accused. And the forensic doctors will not leave me.
Dr. Wissam Habibi, what about the opposite? Well, in my the last months, I celebrated 40 years of acting as anesthetist. starting from resident up to retired professor. Okay, I've never seen a patient died from anemia, but I've seen many died from. Yeah, I'll take your point. What if you are accused that you give the blood, for example, for a patient and with shivering and incompatibility, or even viral transmission, or even we have many complications. If please for يعني عشان خاطري revise the review I said, which is published in 2018, which is more dangerous, anemia or transfusion. You will find that if the patient died after operation, 10% due to anemia, 90% due to transfusion.
But
I know
Can
that
I
this is
comment?
not
easily proved, Dr. Magdy, please, but this will not be proved. If you give a blood transfusion and you have a complication related to this transfusion, you will not be accused, but you will be accused of you don't
correct the anemia.
Who said that? Who said that?
Yeah.
This is a proof.
The first.
حضرتك دايما في كل وقت هيحاسبوك انك ما اديتش، لكن مش هيحاسبوك على الكومبليكيشن اللي حصلت بعد الترانسفيوجن. It's true. It's true. Yes. Believe
Still you don't believe. I know from my
that is why
many of us know my talk, my idea, but you don't believe in your heart.
may I comment here?
Magdy, sorry.
May I comment here, Magdy?
Please 1 second. You are invited, Dr. Safa, to visit us in the Liver Institute operations, and you will see that we are so brave not to give blood.
Please, لا دكتور مجدي نقطة بعد اذن حضرتك، بعد اذن، ده شرف ليا طبعا، ده شرف ما فيش كلام. اللي انا عايزه اقوله لحضرتك ان انا ويز يو في كل نقطه حضرتك قلتها، يعني ابسوليوتلي اجري، لكن انا بقول لحضرتك ده مش عشان انا اجنست الفكره او اجنست المحاضره.
لا انا قلت انا عارف ان حضرتك والله العظيم. بص يا دكتوره
حضرتك فهمني، الاتموسفير حوالينا ملغم ومهووس بالبلاد ترانسفيوجن، فلازم نعمل الفكره شويه.
والله العظيم
فهمني حضرتك.
انا عارف ان انت نو، وعارف ان كل اللي قاعدين كلهم انا ما قلتش كلمه هم ما يعرفوهاش، بس يو دونت بليف. احنا عشان تبليف على فكره اسالي اول مره عشان نعرف الافكت بتاعنا كانت اتنشرت وكان نرمين مش موجوده دلوقتي، لقينا ان احنا لما قارنا بشغلنا مش تاني we gave the patient before الهيموديناميك مونيتورنج والحاجات واللي يعني كنا بنشتغل بلايند نوليدج. لما جبنا الابريتس نوليدج لقينا ان احنا كنا بندي بلاد وفلويدز وي 36% more than the patient need. فانا بقول لك الفكره كلها، انا عارف ان نو، والله نو ما فيش. انا بصي كله بس ودون تو بليف. لا عاوزه وقت.
Can I comment 1 minute here? Definitely, what you're saying, Magdy, is ideal, very good, and we should really all practice blood transfusion free. But in order to do this, we must have an educated surgeon. We must work in a good center which is equipped. We always have evidence throughout our work from apparatuses like you showed in rotor coagulation, like you showed in using cell saver, like having advanced technology. We cannot ask this in a center which is not equipped for this. In us, when we work in liver transplant, we understand we can do a liver transplant free.
المشكله يا خالد موجود. انا اخر بيبر على فكره كنت دايما بحطها في الاول عشان لما بيكون يعني مالتي بحب اهزر مع الجراحين، انما انا حطيت اخر بيبر موجوده والاسئله على فكره اللي عاملينها اسئله فيري مايند، مثلا النورمال هيموجلوبين كام، الفيريتين كام، حاجه زي اسئله عبيطه جدا يعني. لقوا ان الجراحين ما عندهمش، الجراحين هم الفيرست ريسبوندر تو ذا بيشنت. فالمشكله موجوده اول اوفر ذا وورلد، بس عندنا اكتر. اخر كومنت اهوت بيقول لي educated surgeon. انا قلت لك البيبر الاخرانيه اللي اخر سلايد عندي ممكن اجيبها تاني اهي، اللي هي يعني لا يعني بلاش عشان اكل عشان اكل العيش. لا هقول لك حاجه اهي، ده امريكاني مش مصري يعني، دي اهي among cancer في امريكا.
We need Dr. Magdy to take steps. First, today the webinar was very important. it discussed the idea of transfusion-free surgery. Okay,
Yes,
but then we have to support our work by well-equipped center. We cannot work in centers that are not equipped with the necessary equipments for us to practice transfusion-free. We also have to do what Europe did, and now the other Middle East countries are doing, is making available the ampoules that will actually delete blood transfusion. So for example, Cell Saver will delete definitely red blood cell transfusion. Fresh frozen plasma will be deleted by prothrombin complex concentrate ampoules, which should be available. And in many years ago, we had it available in our liver institute, and it had a major impact. Everyone knew about it. Surgeons even knew about it. When we use patient-controlled prothrombin complex concentrate, it was at first 3 factors. Now it become 4 factors. Fibrinogen hemicompletan is available, which will delete cryoprecipitates. So if we have all these ampoules in our OR, we are in no need to give blood transfusion. And nowadays, if I'm going to give you the picture in Saudi Arabia, for example, which is very recent, just only 6 months, hemicompletan fibrinogen is now available, prothrombin complex concentrate is available. But the problem is that surgeons don't know that it is available. Anesthesiologists need someone to educate them that it is available. In Egypt, the situation is it is not yet available in Shara al-Muwahhad. So in the Unified, yes, it is not available. So I did a phone call just before our webinar with the company that provides it, and they said they are doing work to make it available. But we are going to buy it by direct order. We must have these ampoules with us to help us stop it. So in Germany, when I asked them, they told us, our colleague working in anesthesiology in liver transplant, just give me a minute, 12 years he haven't used fresh frozen plasma.
محمد الادمن رفع ايده.
لا احنا عندنا معلش محمد عبد الشافي ثانيه واحده، عندنا سؤال من بروفيسور محمد احمد، الحقيقه سؤال جميل جدا. دكتور مجدي، هو دكتور محمد احمد بيسال حضرتك عن البولي تروما patient and with intraoperative massive blood loss.
Yes,
I admit, in my opinion, in my belief, in my heart, the only permissible, the only ما نضطر غير باغ ولا عاد, the only 2 obligatory massive blood loss. I know you are expert in ob-gyna anesthesia. Just one, I like numbers. I like definitions and numbers. The patient with a lax uterus will yield 3 liters per minute. So no time to patient. No time.
So you have to give blood transfusion.
Yes. Massive trauma.
Welcome, Dr. Muhammad Ahmed. Welcome, Dr. Muhammad Ahmed. Welcome. I hope you have the answer with our great Prof Magdy.
Massive blood trauma. So no question. Give blood.
محمد عبد الشافي اتفضل. محمد عبد الشافي اتفضل.
Yes, I may suggest a solution for this legal dilemma, that we can involve the hematologist in the decision. So if we can write on the notes that hematologists said don't transfuse, and this happens in the UK. I was surprised, even many times you can't transfuse unless the hematologist allow you, especially in platelets and plasma. This is number 1.
My talk like that might not be strange in any country who adopt quality management rules and guidelines. But in my locality, I'm not speaking about all over the Egypt. In my locality, no guidelines, no quality management for blood transfusion. So I'm defending this idea up to the time there will be quality management rules and guidelines who prevent the abuse.
But Dr. Khalil, we all, I don't find English, we all اتقرصنا from legal problems, and most probably we saw ignorant reports coming from our colleagues, very ignorant, outside the guidelines, outside, they don't know anything, just want to find pick up on you, find something to write against the anesthetist. So I think what some doctors say, dilute the responsibility, just find the hematologist and put his name on the patient notes with you. The other thing, we have done a quick study here about the major obstetric hemorrhage. We found that when the major obstetric hemorrhage call or alarm was triggered by the surgeon, most probably the blood is not needed. So we should emphasize that the anesthetist is the one that should ask for blood, not the surgeon. We returned at least more than 50 to 60% of blood that was ordered by the surgeon.
محمد استاذنك، انا ما بعرفش اتكلم مع حد مش شايفه.
تحت امر. ماشي، تحت امر حضرتك.
يلا يا محمد. أبير ولك الأمان.
لا أنا موجود والله.
طب يلا. اتفضل يا محمد.
هي باي ذا واي بس حاجه كده بره البتاع، انا اقول لك الفويس مسج بتتنقل الفيربال كونتنت 8%، الفويس تون 35%، البودي لانجوج 55%. فعشان كده دايما لما التليفون المحادثات التليفونيه بتبقى دايما ضعيفه التاثير.
يعني هو اللي كنت عايز اقوله ان يعني ممكن عشان نبدا كخطوه في جنب الكلام اللي اتقال ان احنا محتاجين equipment والحاجات بتاخد وقت. We can add another, like dilute the responsibility by involving the hematologist in the decision. So and also the department can publish protocols and criteria for transfusion. Then you can resort to these criteria if any dispute happens.
بص انا هقول لك على حاجه دكتور محمد، you are right. اللي يعني انا عاوز اقول لك العالم بلاش اللي العالم ممكن يوصل له ده على فكره ما هوش قديم. يعني انت لو دخلت قلت لك انا واحده ايطاليه مش مصريه خدت 500 سم بلاد في السيزيريان سكشن. طبعا دلوقتي برضك كان ممكن مثلا من 20 30 سنه كان السيزيريان سكشن لازم 500 سم. دلوقتي لا. فهو الحته دي الادفانسمنت بتاعتها حاجتين، واحده فيهم اللاب وزي ما خالد قال كده والدراجز الثانيه النعمه بتاعت الجو ويتنس. العيانين بتوع اللي قال لك ما اموت ولا اخدش بلاد، فلموا الداتا بتاعتهم لا الله ده من الناس هي بتعدي 6 وما بتموتش. طب ليه ما نعملش زيهم؟ هم دول يعني انا مش ده كلامي برضك، ده مكتوب في الليتريتشرز.
ما هم اللي اساتذتنا المحترمين قالوا انك على ما توصل بقى لمرحله انك تفهم بتاع الطب الشرعي وتجيب له البيبر بتاع الجو ويتنس هيكون ضاع منك سنه ولا سنتين في مع النيابه والتحقيقات والحاجات دي. يعني الانفايرمنت منفره جدا للشغل النظيف يعني.
عموما يعني ما اعرفش، انا قلنا اللي علينا وانتوا الشباب بقى ان شاء الله عليكم. احنا بردك ارجع اقول تاني، احنا في المعهد ما وصلناش للثقه دي. انا هقول لك الحاجه، ايام ما كنت في رسم 30 سنه فجيت ايه بقى، كان معايا طبعا كونسلتنت اكبر مني وكده، فجيت بعلق لاكتيت رينجر قال لي وات we are doing only the red and yellow. no دلوقتي احنا بقول لك اتقلبت 30 سنه، اتقلبت خالص، مفيش خالص، ما بنديش خالص. يعني اخر حل مش فاكر انا، يمكن بس ايمان كمال لو موجوده مش عارف الحاله الاخيره ولا اللي قبل الاخيره عملت من غير بلاد.
موجوده مع حضرتك اي دكتور ماجد.
الحاله الاخيره ولا اللي قبل الاخيره يا ايمان من غير بلاد؟
الاخيره
وكانت بري بلاند. يعني الظريف اللي فيها مش احنا اتفاجئنا ان ما خدتش بلاد، لا هي كانت بري بلاند انها مش تاخد بلاد.
صحيح.
الكلام ده كله برضه.
برافو ايمان كمال، برافو.
اهلا بحضرتك يا دكتور خالد.
وفريق معهد الكبد زراعه الكبد ما شاء الله منورنا. دكتوره ايمان كمال كانت مشرفانا في المؤتمر الاوروبي the European Society meeting and she did present a very good case about coagulation monitoring in COVID-19 and she was given a prize for her good presentation there. Excellent. Thank you for attending.
شكرا جزيلا.
الدكتور محمد كان رافع ايده يسال سؤال وبعدين ننزلها تاني.
محمد تريح، اتفضل يا محمد اظهر.
ايوه. الدكتور سمير الكفراوي كمان اتكلم كلام جميل، قال انا عملت 3 حالات Jehovah's Witness for brain tumors and he used autologous transfusion, intraoperative hemodilution and with no blood transfusion. So we have anesthesiologists who believe in free blood transfusion.
ممكن بقى لو عايزين نتكلم عن نيورو سيرجري تاني والثوره اللي عملها الديكستروميتادين. يعني we stopped using blood transfusion in cranial surgery. We stopped using hydrating measures.
Yes.
Dr. Khalid.
Yes sir, تفضل.
I have just a small comment about Dr. Magdy and legal issue.
كاميرا دكتور ياسر،
Camera is okay, you know, because I'm in Russell Bar, I'm sitting on the balcony.
Okay,
sorry.
Why we have
It's okay, this one. I don't know why you're not coming. It's okay, yes.
ايوه شفناك دلوقتي اهو.
They need me just to be, yes, okay. About the legal issue is different from country to country, and I don't agree with Dr. Safa if anything happen. Even if the surgeon push you to give a blood and you have a complication, it is you must be a question. This is a questionable for you, because they look for the guidelines in the hospital and what is the level, as you said, that was level blood to give. And I think one of the best book, right, this 2020, is Morgan and Mikhail case-based study. He gave a big chapter about legal issue of blood transfusion and how to deal with the surgeon. But I think this law in America, and I think we can get this one for a guideline, because we don't have a legal issue in Egypt about the what's called the responsibility. And everything happen, it will be an anesthesia, because they give a bigger dose, as we hear that. But as Dr. Khalid said, as Dr. Magdy said, we must have a guideline for that. We must have a law for that. But even you are responsible in my work here in Qatar, you are responsible whatever you give a blood, whatever the surgeon make a pressure on you or not, you are responsible about the complication. And they will check the case by case for that.
On the contrary, Dr. Yasser, that I've read on the Facebook and one page about the anesthesia, something like that. One anesthetist is working in the KSA, and for cesarean section for unknown, she bled and she went to hemoglobin 9, and he gave her one packed RBCs, and the patient was, I think, do something dangerous like ABA, she went to complications. He was accused. They went to the jail.
Yes. It's not a thing that you know are responsible whatever you give or not.
Dr. Yasser, you're working in Qatar. What's the situation there? Do you have the Rotem there, I think, in Hamad? You have ampoules of fibrinogen PCC. What's happening?
Yes, we have everything. We have everything you imagine and beyond your imagination. And the what's called the hematology included in the case.
I know that you have special circumstances for the World World Cup, and that everything is ready there.
Before that,
Hamad is equipped with something that might come later, not nowadays.
Yes. This is what I'm telling Dr. Khalid, beyond your imagination from few years, not now because of World Cup. Nothing changed for World Cup except to stop our leave only. But you know, this is something behind your imagination and my imagination, because I was working in Saudi when I transferred to Hamad, and also very easy to include the hematology, to ask him to come, because there is a hematology to guide you, to help you.
What is
and
your
there is a policy already.
What is your experience with the alternatives of blood transfusion, the PCC and fibrinogen ampoules? Are you using it, or what's happening?
Yeah, you know, Dr. Khalid, from the time I work in Egypt and the blood transfusion was given like a drug, we consider in Hamad like an organ transplantation. You see, the precaution of organ transplantation. For my work in the last 5 years, I remember only I give blood 2 times or 3 times only for trauma. But in most of the cases, even this last case, I was in argument the hemoglobin was 14, and they have a patient, some bleeding, some tachycardia, and the hemoglobin reached to 8.9. And I get an argument with one of the senior staff. He came from his country, just in you, because in some countries the blood given like like a drug, like everything, like water. And at the end, we follow up the patient become very good and okay without blood transfusion, because you know, I remember one case, someone insisted to give a blood, and they give an what's called blood transfusion related lung injury, and the patient died. And when they investigated the case, the hemoglobin was 9, and they give him a blood because it was 15 coming to 9, and the anesthesia just blamed about the problem, and even there is a push from the surgeon, but the anesthesia not right the push. Even with the push, and even you push, you are blamed because you are a physician, and this is the problem. But you have a certain guideline helping you to do that. Don't follow the guidelines. When you have a stress, follow the guidelines.
أنا سعيد جدا. Please send my greetings to محمد العريف من نبيل شليق.
ربنا يبارك فيك. حاضر طول إن شاء الله.
محمد العريف is a friend of mine since the preparatory school.
Dr. Muhammad, one of the best physician in our hospital, best supportive for his colleague, you know, and is the best for Egypt, showing the Egypt in a bright way.
I know him since 16 years. 6
Yes.
years. 6 years.
I know you for more than 25 years. I attended with you in a conference, but I was young, not an old man like this. Everything changed.
شكرا يا دكتور
دكتور عمر
صفوان.
توفيق.
اتمنى ان احنا نعمل تيرنينج بوينت مش في النولج والله موجود. انا ما فيش حاجه قلتها ما حدش بيعرفها بس تيرنينج بوينت اوف ذا بليف.
No, my great prof. Today you throw a stone in a steady water, and we and you really teaching us when to say yes for blood transfusion and when say no for blood transfusion. Really, for me at least, it was a demarcation, a line of demarcation today. This lecture is highly informative, highly arranged, and delivered very easily and simply. Was very, very amazing one. So I'm very thankful for you, my great prof, Dr. Magdy. You summarize it very carefully and stream it very cleverly. You upgrade my own brackets at least, and this is a very forward step for me to say when I will transfuse or no. It's a very clear point. Thank you, my great prof. This is my comment about your lecture. If I am allowed to comment about you. I'm so young to comment about you, my great prof. My great dad.
You are the owner of this wonderful club, and we are your guests. And we will be invited later on فطير وحمام.
على راسي.
Yes, please continue this good effort, this work, Professor Safa Hilal. And thank you very much, Professor Magdy Khalil. It's been a very informative lecture. I think we learned a lot from it.
We have still a time. We have still more than, yes, we have still more than 32 minutes. If anyone wants a question, اتفضلوا. We have still time.
Floor is open for any questions from the audiences. Yes. But I think that this lecture was very good, and it actually drew the attention that we should work more on transfusion-free practice in our country, including using all the technologies available nowadays and spreading it wider and wider. This is the same situation in Saudi Arabia. They just started 3-4 months ago studying Saudi patient blood management. They want to put protocols, they are doing meetings, they realize that they are using a lot of blood transfusion, and they are working now to reduce it. And this is the time we should start this in Egypt also as well. Okay, floor is open for discussion for our colleagues. Any questions?
دكتور خالد بعد إذن حضرتك أنا فعلا بحلم باليوم اللي يبقى عندنا guidelines how to proceed for hepatobiliary anesthesia, how to proceed for cardiac patient, and guidelines, and it تبقى widely distributed all over our country and everyone ملتزم بيها بيشتغل بيها وخلاص علشان ما يبقاش حد accused based upon personal bias. Everything should be arranged carefully for any case, cardiac, obstetric, and guidelines.
عشان يبقى ضميري مستريح وما اقولش مسج تطلع تتعمل بعد الميتنج ديت تاني. حكيت ليجل ومش ليجل دي. If I leave a patient with hemoglobin 7, hypothermic, shivering, in pain, and hyperventilated, so I'm killing him. Yes. If you are confronted with sudden, please prepare your patient not to lose blood. Prepare your patient not to drop to 7. But if by mistake, if by accident, if by fault, if by enemy, you keep the patient 7, please keep him warm, ventilated, and not extubated in the OR. To be just to prove for the audience or the relatives that the patient is still awake and he hasn't been dead from the anesthesia. This is a criminal. If he came to meet to study his case, this is criminal. Not because 7, because he extubated earliest patient. So you have to keep oxygen donation and oxygen utilization. And I think if the patient died from 7 or 8, he died from not to be ventilated, while it needs to massive ventilation.
Yes, missed something. There is something missed. Maybe comorbidity, maybe obesity, maybe the type of operation, maybe lack of analgesia, shivering, as you see, my prof. like
please keep him ventilated and give him 2 kilos of sedatives, 2 kilos of analgesia, not this is because keep him. Why to exhibit him? You might have 2-3 hours, or for example, if you went by night, it is the morning, and you can exhibit him while he's warm, while he's not in pain, while he's well ventilated.
There is a question for you, Dr. Magdy. If there is a spine fixation operation started at 14 gram hemoglobin, after 2 hours, it's now 9, should we transfuse the patient?
Again, if I have a patient with hemoglobin 14 and drop to, this is my fault. That's because I failed to do something aiding the patient, the surgeon, to stop or minimize bleeding. If I have a patient, for example, like that, with 14, maximally it might drop to 11. But if by mistake, if I'm not preoperative physician, don't think yourself as anesthetist or anesthesiologist who is giving the tube or excluding the tube. Think about this patient preoperatively. Give him tranexamic acid, give him dexmedetomidine, give him positioning, so it will not be bled. That's because if the patient went from 14 to 9, this means that he lost about 2.5 liters. Again, and if you came as a consultant with this problem, 9 is more than enough. 9 is very fruitful. 9 is very wonderful for this patient. And if you give him blood, with I have the reference to be sent to you, the bleeding will increase and surgical site infection will increase.
Please, I have a comment. As being an obstetric anesthesiologist for many years, in cases of postpartum hemorrhage, like abnormal placentation, placenta accreta or percreta or such so, and you have massive blood transfusion on the ground. Number one, I asked my colleagues, number one, devascularize the uterus. This is the which قافل الحنفية. اعمل لي devascularization of the uterus. So when he delay it and do something which not optimum for the patient, I asked him, do you want to have a uterus or a patient? Your patient now is 60/40. Your patient now loses more than 2 liters. What about you? You should now do the sharp decision is hysterectomy. So always be honest with your patient and with the surgeon at the time.
Okay, this is a very excellent model of good anesthetist. That's because I'm not kidding, I'm speaking right. 40 years ago, one of my great professor told me that, Magdy, if you want to be a good anesthetist, you should be excellent in medicine, excellent in physiology, excellent in pharmacology, and surgically oriented. You just said 2-3 tenses that you are surgically oriented. I'm not a surgeon, you are not a surgeon, but you are surgically oriented. You know how to tackle the uterus, how to clamp the uterine artery and so on. If it's not successful, do hysterectomy. So you are oriented about surgery. Number 2, you know the physiology. If you have a patient who is ventilated under anesthesia and his blood pressure is 60/40, it will not be like that a patient, awake patient with 60/40. That's because you are keeping him on your hand. You are ventilating him. You are keeping him. So it is not hypoxic. It is not hypoxia. It's not anemic hypoxia. It is not hypoxic. But you will kill him if you extubate him immediately.
Yes.
A good anesthetist.
Thank you.
Question? Okay. Again, بجد, we haven't reached this information because yesterday we did a lot. We started liver transplantation 2001. It was just to prove what Khalid said. We started liver transplantation while me and Khalid was outside. It was 1991. Why we waited 10 years to restart? That's because infrastructure was not optimum. when we started again 2001, it was excellent infrastructure. The main advantage of dealing with liver transplantation is you should have good infrastructure. By infrastructure, we started to read a lot, to know a lot, to do a lot, and then we gain this experience in this field. For example,
حضرتك واخدين ميزانيه الجامعه يا فندم، واخدين المونيتورز، واخدين ادونا اي حاجه ينوبوا سوا احنا جيرانكم يعني عشان خاطر. دكتور خالد، لن انسى لك كل المونيتورز اللي حضرتك بتجيبها دي، مش راضي تتصدق علينا باي حاجه يعني، باي حاجه ينوبك ثواب يعني.
هي المونيتورز اكشولي مش جايه من فلوس الجامعه، اغلبها تصدقات من رجال الاعمال، يعني مثلا الدكتور الحاج برعي من الازهر، الحاج العربي، اغلبها تصدقات علينا.
قول لهم يا فندم يتصدقوا عليا يا فندم، قول لهم.
في سؤال من الدكتور محمد الادمن بيقول platelet threshold for spinal epidural which threshold do you use? Can I ask Dr. Khalil, Dr. Tol, and I'll go to the Bible. I'll go to the Quran. I'll go to the holy book of transfusion. The French Society of Neurosurgery recommends 80,000.
80,000 also the Royal College of Anesthesiologists in UK. 80,000 is your number.
Yeah. So
بس انا عايز اقول حاجه برضو عشان ده الفيوتشر ورك بصراحه الناس شغاله فيه. احنا عندنا برضو دكتور الانصاري، مجدي الانصاري، شغال في ابو ظبي في مستشفى الكورنيش. He has a very good experience in obstetric anesthesia because it is an obstetric hospital, and he's doing a lot of work with the placenta previa and massive bleeding by monitoring the coagulation using rotational thromboelastometry. They have it there, and they are practicing it and using the guidelines. And in last meeting last month in Riyadh, they were talking about Munich and many centers now in Europe that is monitoring the coagulation of the patients with the viscoelastic tests. So viscoelastic tests is starting to become of an important role in managing obstetric hemorrhage.
It is a growing role. Yes.
It is growing role. So we really should think about this.
Yes. But for us here, it is just a dream.
No, it is not a dream. We have
For the daily practice, you have 15.
And Imad Kamel is with us here. We are planning to bring number 3, the new one. Imad Kamel, I think, is here. Iman Nawad is here. We are planning to bring number 3. Just buy it as if it is a ventilator or an anesthesia machine. And then your practice will change a lot.
Okay. Yeah. We'll search about it.
Platelet count or function
عشان يكون fair enough. الروتم هيخليكي تحلفي على اللي بتعمليه. يعني بمعنى مثلا لو انت عاوزه تعملي ابروتش دراجز كده في الاوبجاينا بتاع اللاب مش هيبروف ولا ديسبروف. الروتم هيخليكي تحلفي على اللي انت بتعمليه. this increase or decrease or sustain and sustain. هو الروتم بيبقى كانك انت فرق ما بين ان انت تحطي ايدك على العيان كده ولا تفتحي بطن العيان وتشوفي دي الانتستين ودي الليفر ودي اليوترس وبتاع مش هو كده. فهو الروتم ده يعني عشان كده بقول لك احنا لما اتجرأنا وحلفنا يا لا ما تديش هنا، لا تدي هنا، ما تديش. يعني مثلا can you imagine that the patient is coming after liver transplant immediately with INR 3 to 4 بس الروتم ما تطلعش 3 to 4 يبقى المفروض دلوقتي انه ننط في كرش ونديله بلازما لو على القديم يعني. انما بالروتم لا ما بنديش.
صحيح. في حد بيسأل سؤال platelet count or function is the most important. بالنسبه لنا احنا في الليفر ترانسبلانت ممكن يدخل يعمل ليفر ترانسبلانت ونو بلاد ترانسفيوجن برضه ويبقى platelet count بتاعه 20,000. لان الفانكشن بتاعه ممتاز معوض. فطبعا احنا بنلوك at the platelet function. بس لان حضرتك شغال ومعاك شغل
دكتور محمد
دكتور خالد بليز. دكتور خالد ابوينت نقطه نظام. دائما وابدا ببص على العيان بتاعي if I have not a petechiae or a skin rash and I sure this is not an insect bite or other, it's okay. If the patient have no ecchymosis, no orificial bleeding, and no other data that suppose that I have thrombocytoathenia. So دائما وابدا اقول لهم it is not the platelet number, it is the platelet function.
انا زعلان من الدكتور محمد الادمن.
ليه؟
سأل سؤال بيزعلني قوي يا دكتور محمد. How much
لا السؤال ده سبورتيف مش اجينست، مش السؤال
How much it costs. بص يا دكتور محمد، وانت في بدايه حياتك ما تحطش ما تحطش سيلينج لتفكيرك. يعني عارف اصعب حاجه تيجي السيلينج بتاعك متر ونص، اول ما تقوم ما تكونش يخبط دماغك وجاي معاك تاني. لا، سيب دماغك. يعني انا لما رحت فرنسا اتعلمت الحته دي كويس قوي. انا كان هنا طالع طبعا ايه فلكسديل ولا دي تيوبوكلارين، ايام الحاجات اللي انتوا ما تسمعوش عنها دي، ومش كان لسه التراكيوم لسه طالع. يا نهار اسود نجيب تراكيوم يا لهوي. فكان ايه عندي السيلينج بتاعي. لما رحت هناك لقيت الشلف ورايا، الشلف في كل حاجه. يعني الحاجات اللي انت ما سمعتش عنها في الجاما هيدروكسيد، الايتوميديت، الكيتامين، الانترافال، البروبوفول، كل الشابتر بتاع الانترفينس لقيته ورايا. فكان بقى ايه مالكش حجه. فعندك مثلا عيان هايبر كاليميك داخل مثلا لازم يخش عمليه والبوتاسيوم بتاعه 7، هات جاما هيدروكسيد. عيان كارديوميوباثي هات ايتوميديت. وبرغم من كده كان بردك في فما انسى خالص موضوع الفلوس ده، بالذات ان انت لو انت ستاف جامعه.
تعليق برضو على الجزء ده، الروتم سيفز لايفز، ودي كانت واضحه جدا في حاله برضو كانت عايزه تعمل هيستريكتومي وكان عندها سيفير فايبرينولايسيس في اسكندريه، وخدنا لها روتم لقينا السيفير فايبرينولايسيس لا يمكن ابدا كان حد يشخصها الا بالروتم، وخدت ترانكزاميك اسيد اند شي واز سيفد.
انا ممكن كنت اشخصها لك خالد من غير الروتم يعني، بس اشخصها لك من غير لا تشخيص.
It saves lives. Yeah, this is true.
ماشي لا هي سيب. بص يا خالد، تسيب لايف امتى؟ اقول لك ان انا اشخص فايبرينولايسيس برايمري او سكندري باللاب اقدر. ان انت تقول ده سيرجيكال بليدنج ولا كواجولوبسي، هو ده.
ايوه ميديكال.
يعني دي اللاب العادي ما يجيبهاش.
ودكتور محمد عبد الشافي طبعا انت شغال في انجلترا طبعا وشايف طبعا اتس افيلبل ايفري وير والتاج از افيلبل. والفانكشنز بتاعت الفيسكولاستيك تيست، هو ليه الفيسكولاستيك تيست مهم؟ لان هو بيلوك ات ذا بلاد كواجيليشن وكل الكومبوننتس اوف ذا بلاد موجوده، ار بي سيز وبليتلتس وكله. ليه الاي ان ار والبروثرومبين وبارشال ثرومبوبلاستين تايم مش دقيق في قرايته؟ لانه بيعملوا له سنترفيوج ويشيلوا كل الكلام ده وياخدوا البلازما يستخدموه. فواحد يعني
انا قلت لك يا خالد هو المعمل بيجاوب الكواجيشن فاكتور دي نسبتها كام بس وده
بالظبط.
العين البيربر لو انت حطيت ايدك فيه هيسح مش هيقفل، بس تشوف الاي ان ار بتاعته نورمال والبي تي نورمال.
وعيان الليفر بيبقى داخل اي ان ار 2 و3 وعنده بورتال فين ثرومبوزيس.
لا عندي ثانيه بقى اهم، بس عنده دي في تي عشان بس البورتال فين ثرومبوز ده يمكن شويه لوكال. عنده دي في تي.
ايوه مثلا
خالد
الحقائق دي ما بنقدرش، لازم خلاص احنا بقى الحاجات التكنولوجيا المتقدم ده محتاجين نستخدمه. الجراحه ما شاء الله عليهم بدأوا يوفروا كل حاجه متقدمه ويجيبوا كل اللي هم عايزينه. احنا كأنستيزيا برضو لازم نكون على هذا القدر.
يعني صعب جدا يا محمد
مع حضرتك اللي لازم ابقى فولي ايكويبد مع حضرتك ابقى فولي ايكويبد لكن my clinical sense and my clinical
مهم
يعني
بص دكتوره صفاء
I should have an eye of an eye of female. I should have.
لا بص يا دكتوره صفاء، الكلينيكال سنس بيزيد باللاب والاباريتس ما بيقلش.
طبعا
لو بس اخد لاب واشغله، يعني اخد لاب واشغل بدماغي.
ماشي.
انا حاسس ان انا كده زهقتكم الليله دي ودخلنا
ابدا
واضح ان في 5 6 بس الموجودين والباقيين كلهم روحوا يطبخوا.
نو احنا مور ذان 24 يعني
25
لا ما في الباقي انا عارفهم اصلا. انا بشوف ما وراء الكاميرا في باقيين راحوا بقى يحضروا العشاء للولاد.
او بيتفرجوا على ماتش الزمالك 2-0.
لا بلاش الزمالك يا دكتور خالد. احنا الحقيقه this was a very nice August night يعني، والحقيقه يعني كان لقاء ممتع وثري ومعلومات رائعه، يعني اشهد الله انها معلومات رائعه. انا اول المستفيدين منها واول الناس اللي هتطبق كل كلمه فيها حرفيا باذن الله، واعلم للشباب عندي في القسم باذن الله. كل الداتا دي. وطبعا المحاضره دي اول ما تبقى ريكوردد انا هحطها على التليجرام بتاع الجروب. بشكر حضرتك دكتور مجدي، بشكر حضرتك جدا جدا جزيل الشكر. ربنا يدي لحضرتك الصحه وطول العمر، وتعيش في رغد العيش ان شاء الله، ويرزقك خاتمه الصالحين ان شاء الله. استاذ الدكتور خالد ياسين، انا متشكره جدا جدا لحضرتك على قبولك الدعوه ان تكون مودريتور. الحقيقه انت النهارده كنت اوت ستاندنج مودريتور، كل حاجه منظمه جميله، الاسئله رائعه. بشكر كل الاتندي، بشكر كل زمايلي المحترمين اللي جويننج اس، وان هم يعني اجل ان هم يعملوا upgrade and change their daily challenge in their daily practice. وبشكر حضراتكم جميعا وشكرا جزيلا، يعني كان يوم ممتع الحقيقه. متشكره جدا جدا.
جزاكم الله كل خير وبالتوفيق للجميع. شكرا دكتور مجدي، سعيد جدا ان انا شفتكم جميعا. شكرا دكتور محمد الشافي، محمد احمد، كل زملائنا وفريق العمل في محافظه المنوفيه.
شكرا لحضرتك يا دكتور خالد، وحضرتك احضر معانا تاني، حضرتك بقيت مختفي شويه. مستنيه حضرتك.
ابتسم انت في المنوفيه.
بعد 10 ايام لما تنتهي الاجازه ان شاء الله هنكون كلنا متواجدين معاكم
ان شاء الله. ان شاء الله.
شكرا.
إن شاء الله.
شكرا.
في رعايه الله وامن، في رعايه الله، في رعايه
السلام
الله،
عليكم
في رعايه الله. مع السلامه، مع السلامه، مع السلامه، مع السلامه. شكرا يا الله يكرمك.